First, I should thank my friend Dr. Matthew and Titu for the wonderful opportunity given to me. And this topic is a very unique topic. Okay, see something very important in our clinical practice, which most of the time we are not looking into. The topic is osteoporosis, and the bone health is really important for us before choosing a molecule for the treatment of type 2. There's a definite link between osteoporosis and type 1. The bone mass occurs, or peak bone mass occurs around 30 years. So suppose if you have a patient develops diabetes mellitus at a younger age, they will not develop peak bone mass. So eventually what will happen? You will develop weak bone, or you can call it as osteoporosis. And in addition to that, especially for type 1 diabetes and all, you have a lot of cytokines, which is also contributing for your bone health. So if you see this diagram, see what is written here. In the initially up to 20 years or little later than, you'll get maximum bone mineral density, and subsequently that is coming down. That is what is happening in normal individual. Suppose a patient gets diabetes also, what will happen? The peak bone mass is not achieving properly, and the reduction is also significant. So in effect, these patients are high risk candidates for developing bone changes, and subsequently fracture is possible. Now there's a beautiful diagram which is given in 14th edition of Williams. What it shows, the insulin is favoring the function of osteoblast as well as the osteoclast. So if you can read the lower part, under carboxylated osteocalcin, which has got some positive impact, it will increase the insulin sensitivity and insulin secretion. So what I want to tell you that there is something like a crosstalk which is happening all the time between adipose tissue, insulin and bone. Now the link, if you look into the data again and again, what I want to tell you from this slide, even in type 2 diabetes mellitus, there is a risk for fracture, and in type 1 diabetes mellitus, there is no doubt about that fracture risk is high. So these are the studies conducted quoted in the various literature. IO human health study, lot of people were included or enrolled for the study. Even for type 1 diabetes also, lot of patients were involved, around 8 lakh patients. So what is the take-home message? Take-home message is very, very simple. So diabetes mellitus and bone has got definite relation. Eventually, diabetes can affect the bone strength, subsequent fall. Now, this data from Osteoporosis International Journals around 13 years back, this indicates on the left side, you can see the fracture risk of for type 1 diabetes mellitus is very, very significant. But fortunately, common type of diabetes mellitus fracture is not very common. Now, if you look into the sites for fracture, what are the sites? Is it spine alone or is it hip alone? What it shows, you can see this, any fracture, the p-value is very, very significant. And see, only the lower arm fracture, it was not very significant. So the take-home message from this slide, see, all areas in our body, starting from pelvis, upper arm, spine, everywhere, the risk of fracture is increased in type 1 diabetes mellitus. This is a bird's eye view of frequency or the prevalence of osteoporosis or fracture. The 2 dozens of studies you can see from the literature. So what is the link between the fracture and bone fragility? On the left side, you can see there is hyperglycemia and low bone turnover. That is one hand. Another, the mid panel, there is hyperinsulinemia. See, production of advanced glycogen end products, and the treatment is also contributing for that. And there is a high incidence of hypovitaminosis, especially this part of world is very, very common. So what will happen? The eventual result would be low bone quality. And on the right side, there are other risk factors which is producing little bit extra incidence of fall, and eventually because of these 3 factors, the risk for developing fracture is very, very high. No, this is very simple diagrammatic representation. This is control. Once the patient develops fracture, you can see here a lot of porosity. So eventually this patient will go for lot of fractures. Now coming to a very controversial issue. What is the diagnosis? Is it the classical 2.5 or is it more than that? Please read. There are little modification in the T-score is 0.59 and 0.38 for males. This is what is happening. So it's not the usual type of definition. You should modify the definition. This is clearly written, clearly showed in the studies and quoted in 14th edition of Williams. Now, let us examine what is happening with poor control. So if you see the glycosylated hemoglobin of 10, the fracture risk is very high. So with a very good glycosylated hemoglobin, fracture risk is high. Now people are looking in a different way. What about the difference between standard and intensive glycemic control? What it shows, significant difference in the BMD between standard or in the intensive treatment. They looked into the total hip, femur, neck, lumbar spine, and whole body. There is no significant difference was noted in terms of B. Now, coming to the fracture or fall, it also shows the increase in the risk of hypoglycemia in intensive treatment, but there was no increased risk of falls. But one thing is very sure, good control is essential. Now, coming to the most important for a practicing physician, practicing diabetes mellitus, what is the impact of treatment agents? There are negative impact with a certain molecule, especially glutathione controversy. There is something known as a good molecule. There is something known as neutral molecule. We'll examine. So this is the effect of metformin. Metformin is a good molecule in many ways. Basically, that will increase the level of AMP bar ATP level. Eventually, the Wrangle system is getting modified, and Run-X2 system is also modified. The patient's osteoblastic system is very good. So what will be the result? Your bone density may be good, and on the lower panel, you can see the osteoclastic activity is being suppressed with metformin. So eventually, metformin becomes one of the fanciest molecule for the bone health. Now, coming to the controversial molecule, what is this glutathione? Glutathione, everybody knows that the glutathione is good molecule for selected group of patients. But most important issue is little bone problems, and of course, controversy I'm not discussing here. So what exactly is happening here? You can see here the mesenchymal stem cell. In presence of glutathione, what will happen? A lot of fatty or adipose tissues are coming up. So in the osteoblast, quality and quantitatively that will come down. And marrow adipose tissue structure is also altered with your glutathione. So finally, this patient, especially for ladies, thin patients, you can get more fracture, more fragility fracture with the glutathione. This is a study from ADOPT study. What it shows, you can see the incidence of the blue line, you can see here, the rosiglitazone, the fracture, the cumulative incidence of fracture was high compared to gliburate. Gliburate was okay in the ADOPT study, Khan's paper. Gliburate was okay, metformin was okay, but rosiglitazone is a negative molecule in terms of bone health. Now, there are a lot of meta-analysis, randomized control studies you have, where it clearly showed low-risk women, 1 fracture per 55, and high-risk patients, definitely patients high-risk candidates for vascular bone fracture. So what would be the carrier message? Carrier message is very simple. Glycosylated, sorry, the glutathione has got a negative the impact on bone health. Coming to the good molecules, that is GLP receptor agonist. GLP is expressed in osteoblasts, is good. That will help for the remodeling. GLP2 receptors were the osteoclast class, so eventual or finally there will be a reduction of bone reabsorption. So what I want to tell you that in incretin-based treatment, you have evidence-based medicine also for liraglutide. There are certain data which showed the increase in the BMD, of course the animal data only, and exanitinide unfortunately did not show any significant improvement in the BMD. Of course, controversies are there. These are the mechanisms. See, good effect on the osteoblast on the right side you can see, and negative effect on the osteoclast. So what will be the effect if you are using GLP or incretin based treatment? At least the bond friendly attitude of the molecule you can see. So this will be one of the good molecule if the patient has got osteoporosis. And coming to the second part of the DPP4 drugs, definitely these molecules are good because that can increase the calcium accretion, and these receptors in the osteoblast, that will reduce the apoptosis also, and that will inhibit the PTH or parathyroid PTH induced bond resorption, and thyroid C cells also express in the GLP-1 receptors, and their activation stimulate the secretion of calcitonin. So this will be a potent inhibitor of osteoclastic resorption. My friends, what I want to tell you that these molecules got a good impact on bone health. Sitagliptin showed significant improvement in the vertebral BMD, with vildagliptin also showing some green signal, and one trial which showed the effect of glycoside, sulfonylurea, which showed all these molecules are good, especially these DPP4 molecules. Now, so SGL2, little controversial point. Canvas trial was a negative trial in terms of bone health, but it is not really replicated in the subsequent study. Empagliflozin, no significant risk was documented in the EMBARAC study, and dapagliflozin also probably there is no risk at all. And one Cohen et al., they investigated the efficacy or the friendly attitude of dapagliflozin in mild renal failure also. And everything put together, these molecules are good in terms of bone health. Now, there are a lot of mechanisms which are described for the increased fracture risk with SGL2, postural hypertension, loss of fat. So less aromatization, less estrogen, eventually bone will become little more weak, and SGL2 leads to poor bone mechanical quality. So there are a lot of mechanisms are operating. Eventually this can go for, theoretically this can go for fracture risk. Simple diagram. Metformin is a good molecule, and GLP-1 and DPP4 molecules are good because of multiple mechanisms, except glitazones, which has got a negative effect on bone health. Now, coming to the biomarkers, you can concentrate only the central one. The glitazones bond resorption is very, very high. It is not a good molecule for us. Here it's okay. See the metformin, sulfonylurea, and incretin is very good. So glitazone is not good, sulfonylurea is okay, metformin is okay, GLP and the incretin based treatment is very good, and SGL2 little controversy is there, and insulin is a neutral one. Now, considering all these issues, the people are coming with the rotor recommendation. This is published in JCM 2017, and Ferrari article also. What it shows, you go for the BMD. Accordingly, you can categorize a patient. Of course, all patients you should give calcium and vitamin D, anti-fracture treatment, good anti-resorptive agents are there, and the maximum experience with the anti-resorptive agent. But coming to the anti-diabetes management, you have three group of molecule: neutral or positive effect, that is metformin, DPP4 drugs, and GLP receptor agonist. Risk of hypoglycemia, because of risk of hypoglycemia, insulin probably little problem, and sulfonylurea it's okay, say neutral effect. But please, my friends, use with caution. Two group of molecule, one is glitazones and other one is SGL2. Now, I conclude my friends, ladies and gentlemen, and remember, type 2 diabetes mellitus is a risk factor for vascular disease, and a comprehensive management include your vitamin D, calcium, and anti-resorptive management. That's a standard recommendation. And if you are choosing a molecule for the treatment of diabetes mellitus, look into the bone aspect and choose a good molecule which is friendly with your bone. That is very, very important. Let me stop here. Thank you very much for the kind attention, and once again thanks to the organizing team for the wonderful platform. Thank you. Over to organizers.